Hi, everyone. Can you hear me okay? All right. I'm very happy to be here to present some data from a study that Laramie Smith and I conducted in Tijuana, Mexico. We just finished conducting this study. We just finished collecting the data earlier this fall. It's a small study in terms of sample size, but it's really a passion project for us. It took a lot of time and energy, so we're really excited to present some initial data to you today. I'm also just happy to be here among adults. I'm currently on maternity leave. I had a baby 2 months ago, so now I have a three-year-old and a 2-month-old at home, and so it's just nice to be here. Okay, so, thank you. All right, so some brief background. First, I just want to say, for the sake of time, I'm going to try to breeze through my presentation and try to be as thorough as possible, but if anything is confusing, please feel free to raise your hand and stop me and ask a question. Brief background, we know that engaging people into HIV testing, treatment, and care is really essential to improving not only individual health, but also for broader public health to help prevent onward transmission. This study focused on syndemics. How many of you have heard of this term before, of syndemics? Okay, some of you. So this was a term that was coined by Meryl Singer, who's a medical anthropologist, in the 1990s, to refer to a synergy of different psychosocial and health problems or epidemics, hence this term syndemics. And in the HIV literature, you might be familiar with the SAVA syndemic, or the confluence of substance abuse, violence, and AIDS. And syndemic theory basically argues that among disadvantaged and marginalized populations, these types of psychosocial health problems tend to co-occur and put individuals at increased risk for poor health and disease, including HIV. And basically, across the syndemic literature, the basic robust finding that we see is that the greater number of psychosocial problems that people report experiencing is also associated with increased risk for HIV. So it's been shown to be associated with HIV status and also with risk behavior, specifically non-condom sex. Now, a meta-analysis was done on the syndemic literature to show that most of this work has been done with HIV-negative, at-risk populations in the United States, specifically men who have sex with men, and to some extent on racial minorities and women. And really, not much research has been done looking at syndemics among HIV-positive people outside of the United States. And our work is in Tijuana, Mexico, which is located about 25 miles south of here, where, as Dr. Martin mentioned, we see a concentrated HIV epidemic. Across the entire country of Mexico, HIV prevalence is about 0.2%, but we saw what the prevalence is among these key populations. Among people who inject drugs in Tijuana, the prevalence is about 7%. Among female sex workers, it's about 5-6%. And among men who have sex with men and transgender women, the prevalence is about 1 in 5, 20%. And previous work by my colleague Laramie Smith and others has shown that among HIV-positive people from these key populations, we see very few of these individuals are actually engaged in care. So we wanted to build upon this work on syndemics that, again, has focused on HIV-negative populations to see how it might be related to barriers to HIV care. Specifically, our aims were to examine syndemic variables among out-of-care HIV-positive individuals from those key populations I mentioned, to test whether syndemic load is associated with barriers to HIV care among the sample. Specifically, we hypothesized that people who report a greater number of psychosocial problems or syndemic problems will also report a greater number of barriers to HIV care. And this was a study that we collected the data at Preven Casa, which is a community-based organization located in the Zona Norte in Tijuana. And the Zona Norte is really where the heart of the epidemic is in Tijuana. It's where most of our people from our key populations who are living with HIV congregate and reside. Preven Casa provides lots of great services to the community, including basic medical services like wound wound cleaning, but also they have a syringe exchange program. They do STI testing, provide free condoms, and lots of other great things for the community. This is a photo of just some of our hardworking staff who are working on the project, and they're at Previn Casa in that photo. We conducted a longitudinal study, but I'm just going to present some of our baseline data. Our research protocols were approved by the institutional review boards here at UCSD and also at the University of Xochicalco in Tijuana. Participants provided written informed consent. Remember, we recruited out-of-care HIV-positive individuals from these key populations that I mentioned between 2015 and 2017. Out-of-care participants were classified as such by review of medical records, and so this could mean a number of things. It could be newly or previously diagnosed and never linked to care, or have linked to care but at least 90 days past due for their next clinic appointment. Eligible participants had to be a member of one of these key populations by indicating specific behaviors. So, for example, they had to indicate injecting drugs in the past 9 months, exchanging sex for money, drugs, food, or other goods, identifying as a man or a transgender woman, and reporting anal sex with another man in the past 9 months. Participants had to be at least 18 years old, and also because it was a longitudinal study, they had to have no plans of leaving Tijuana in the next year. Now, as you might imagine, it was very hard to recruit our participants. These are hidden populations, stigmatized populations, and by definition, they're hard to reach, right? They're out of care. And so we, and by we I mean our really hardworking staff working at Previn Casa, employed a number of different strategies to recruit our participants. We screened individuals accessing services at Previn Casa. We did extensive outreach to other local community-based organizations to get their buy-in and also let them know what we were doing with the study and with working with these populations. We conducted community health fairs promoting HIV testing in the Zona Norte and also at outlying drug treatment centers. And we also recruited participants by relying on participant and CBO staff referrals. And in the end, and by that I mean when the money ran out, we were able to recruit 54 participants, which we're very proud of. Our participants completed a paper-pencil survey during a face-to-face interview by one of our trained staff members, and the interviews were conducted in Spanish. And we collected a bunch of data. We collected sociodemographic data, and these are the 5 syndemic variables that we measured. We measured depressive symptoms using the Beck Depression Inventory. Participants were given a list of illicit drugs, and they were asked whether they've used these drugs in the past month in separate items. They completed the short version, the 3-item version of the audit for us to measure risky alcohol use. We asked about different experiences of child abuse and whether they've experienced that in their childhood. And also, they were presented with different types of violence and were asked whether they experienced these in the past year. Now, for syndemic load, we used the typical approach to operationalize syndemic load that's found in the literature that I talked about that's been done with HIV-negative populations, in that we dichotomize each of these variables, each of these 5 variables, for example, to indicate whether or not a participant screened positive for moderate or severe depression, have they experienced childhood abuse. And then these variables are summed together to create a composite score of syndemic load, or others have called it syndemic burden. So this is a continuous variable, and participants could report experiencing none, 1, 2, 3, 4, or all 5 of these problems. To measure barriers to HIV care, we use a scale that has been published in the literature, but we also adapted it based on some of our previous work with out-of-care HIV-positive populations, and also to specify it for the context of Mexico. And these are the 12 items in the scale, and participants were asked, since being diagnosed, did you have difficulty accessing HIV care for any of the following reasons? And so they answered yes or no to all 12 of these separately. And these items were also summed to create a continuous variable of total number of barriers to HIV care. Some examples on the scale are unable to pay for HIV treatment, did not have transportation to HIV care, been treated poorly when receiving HIV care. Okay, so as I mentioned, we recruited 54 HIV-positive individuals from those key populations. Most of those participants were men who have sex with men, about 60%, 37% people who inject drugs, and about 23% female sex workers. That doesn't add up to 100% because the groups are not mutually exclusive. For example, we had some people who injected drugs but were also female sex workers or MSM. You could see our sample characteristics. About half of our participants identified as male and reported being deported from the United States. About a third reported having a current spouse or steady partner and dependent children under 18 years of age. Only 37% of our sample completed high school, and most of our participants did not have any current formal employment. And about 60% reported having a monthly income of about 2,000 pesos, meaning that 40% of our participants were living on less than $120 a month. Given that, we also saw a lot of housing instability and food insecurity, with about 74% reporting this type of resource instability. Here is the prevalence of the different syndemic variables that we measured. You could see that about 40% reported moderate or severe depression. Not surprisingly, 60% reported any drug use in the past month. About 30% were screened positive for hazardous alcohol use. And a staggering proportion of our participants experienced some form of violence in their lifetime. About 80% reported child abuse, and about 90% reported some form of violence in the past year. For syndemic load, as a reminder, this is a variable that's summing these 5 syndemic variables, and you can see the distribution of this variable in this figure on the right. 31.5% reported having 2 problems, and then if you add up the bars on the right, about 60% of our participants reported at least 3 syndemic problems. So before we tested our hypothesis of that syndemic load is associated with barriers to HIV care, we wanted to first look at sociodemographic correlates of syndemic load. And what we found was that participants who were older and who also reported housing instability or food insecurity were significantly reported at a higher syndemic load at a significant level. And so taking these 3 variables that were associated with syndemic load as covariates, after controlling for these 3 things, we found that, as predicted, syndemic load was predictive of barriers to HIV care. So this is a linear regression predicting barriers to care. Participants who reported a greater number of psychosocial problems also reported a greater number of barriers to HIV care. So post-hoc, we were interested in looking at, okay, well, what specific barriers does syndemic load seem to be associated with? So this is results from a series of logistic regressions in which we took syndemic load as the independent variable to predict each item from the barriers to HIV care scale separately. And we found that syndemic load was associated with 3 variables. Specifically, participants who reported a greater number of these psychosocial problems were also significantly more likely to report not having transportation to their HIV care, being unable to pay for travel to their HIV care, and also saying that they no longer cared about themselves to get HIV care. So just a summary and conclusion. remember that one of our aims was to essentially just examine the prevalence of these syndemic variables in our sample among these, focus on these key populations. And we found that violence and drug use were most prevalent in the sample. Half were moderately or severely depressed, and 1/3 reported hazardous alcohol use. And so we've built upon the previous literature, again, that's been focused on HIV negative populations to show that syndemic load is associated with negative outcomes. In the work that's been done with HIV negative individuals, again, we've seen that syndemic load is associated with higher risk behavior and also with HIV infection. Here we show that among HIV positive individuals from key populations in Tijuana, syndemic load is associated with reporting greater barriers to HIV care. Because having a higher syndemic load is associated with HIV, it's not surprising that most of our current sample reported at least 3 syndemic problems. Syndemic load was associated with resource instability, not surprisingly, right? These individuals are dealing with a whole host of problems in their lives in addition to resource instability. But apart from that, or controlling for that, we still see that syndemic load is associated with reporting greater barriers to HIV care. And the primary barriers seem to have to do with transportation, being able to get to HIV, to their care providers, and to pay for travel. So one thing I didn't mention that I'll tell you now is that in Mexico, HIV care is very centralized. HIV care is delivered through Capacites, and in Tijuana, there's only one Capacites located in the city, and it's located about 20 miles from the Zona Norte. If I live in Tijuana, so I can tell you, it's hell. It would be hell driving from the Zona Norte to Capacites. It would take, taking different buses or an expensive cab ride and, taking off a day from work to get to an HIV care appointment. So it's not surprising that, transportation is a huge barrier for members of our key populations. And then we've been thinking about this item of no longer caring about themselves to get HIV care. This was an item that we added to the Kalichman HIV barriers to HIV care scale, and we've been thinking about, does this have to do with depression, just general not caring, or could it be something that's related to stigma, an internalized stigma, that they've internalized, the stigma and discrimination that they've experienced in their lifetime, to just generally not care enough to get treatment. And obviously, all of these findings have implications for intervention design. In order to engage members of these key populations into care, into treatment, into helping them to be adherent to their HIV medications, we need to take into account these syndemic variables, depression, substance abuse, alcohol use, and resource instability, transportation issues. So our interventions really should be multifaceted in those ways. And given, like I mentioned, the fact that HIV is centralized in Mexico and in Tijuana and these transportation barriers, perhaps we can also consider telemedicine programs housed at the CBOs in the Zona Norte, for example, at Prevencasa, for example. That's all the time I have. I just want to thank you all for listening, and to thank my collaborator, Laramie Smith, and really our hardworking staff working on this project that we called Conexiones Saludables, Healthy Connections.
Thank you very much, Eileen. So we have time for about 1 or 2 questions. If you'd like to come forward and ask a question. In the meanwhile, I will ask one. So I'm interested that you said that this concept of this metric of syndemic load has been mostly applied to non-HIV positive populations, and you're looking at not only HIV positive, but these sort of key populations at risk. So how applicable do you think that metric is? Do you feel like it's encapsulating and incorporating all that you would like it to? Have you thought about weighting things differently in that, and just Could you comment on its usefulness and applicability?
Yeah, I mean, that's a really great question, and it's something that's come up in the syndemic literature, mainly because in syndemic theory, as it's written by Merrill Singer, he talks about this synergy, this how these multiple health problems and psychosocial problems, how they interact to put people at risk for poor health and HIV. And so it's this metric of syndemic load has been criticized by being simplistic, right? It's an additive approach as opposed to looking at how these problems are interacting together to put people at increased risk. Interestingly, it wasn't Singer who proposed measuring syndemics in this way. It wasn't until 2003 when Ron Stahl published a paper in the American Journal of Public Health on MSM where he used this approach. And since then, that's the approach that most of the studies have taken to measure syndemic load. I think that if it depends on the research question that you're interested in, I do think it is still useful among HIV positive individuals, and with research questions like these, we're just interested in looking at this burden. Syndemic burden is another term that's been used for this variable. To what extent is just dealing with all sorts of problems associated with different outcomes? Now, if you're interested in the syndemic construct itself, and testing the theory, then a different approach would be obviously probably more useful, maybe testing interactions. Another approach that has been used is to measure syndemics as a latent variable, so in structural equation modeling where the different problems are used as measured indicators of this construct syndemics. And in that way, it can be useful to think about, how and to what extent each of these problems is contributing to the syndemic. So you could see different weights in an SEM model. You can see the meaning of the syndemic latent variable and compare it across different groups. Kiyomi Tsuyuki and I have a paper where we did that, where we measured syndemics as a latent variable, and we compared the latent construct between MSM, heterosexual men and heterosexual women, and you see that it does look different. So I think it just depends on your research question.
Thank you. Is there any other questions? Okay, thank you again. We'll move on.